Conference recording started.
Welcome. I'd like to thank you all for attending the California Hospital Engagement Network webinar on reducing readmissions. Good morning, and my name is Martha Ackman, and I'm one of the clinical improvement advisors working on the CalHEN project. The primary purpose of today's webinar is to share the organizational success with peer colleagues in the CalHEN. Covenant Plainview Hospital has graciously agreed to share their care transition program, and you are invited to chat in questions you may have for Leslie Hackett during her presentation, as there is time allotted to address the questions later on. Leslie's presentation will be followed by Kim Workmeister, who will be sharing on health literacy. By this morning, you should have received a link to view the PowerPoint and participate in the call. The phone number is in the chat box, so you can dial in to listen. Well, I'm so excited for you to hear what Leslie and Kim have to share. I want to start with a few housekeeping issues. Sorry. Okay. Today's webinar is being recorded live with an interactive segment after the presentation. At that time, the lines will be opened up. So I would ask that you please use the mute button if there's background noise in your facility, and not to put the phone on hold, as that gives us the privilege of listening to your hold music. This slide gives you a quick orientation to the screen, and you will see at the top of the screen is a computer audio. The chat box is on the bottom right, and you can see where people are already starting to chat in. This is where you can chat in your name and where you're from right now. And also, if questions arise during the webinar, please go ahead and chat them in there. As I said, we will have a live interactive, but that way you won't lose your question. The slides are available to download in the box just below the presentation on the bottom left, and the direction or the link for the CEUs on the bottom right. Okay, so this is our first polling question, and we just want to get an idea of who is in the room. So if you would please note who you are. While we're waiting for the tally, I want to just, again, thank you for coming. We know that everyone has very busy schedules, and so we will keep us on track here. We'll give it just a few more minutes. I am so excited about this webinar. You guys are just like going to be really, really pleased to hear the great work that is being done at Covenant. As you can see here, we'll go ahead and we will close the polling question just so that we can go on to the next. And as we can see, a fair amount, 71% are quality directors. There's a good percentage of both nursing leadership and case management represented, as well as hospital leadership. So thank you all again for taking time from your busy schedules. We'll go on to polling question number 2. And so on this polling question, it is around the issue of patients not following their discharge instructions. And so please check the respective box. Readmissions are a result of patients not following discharge instructions because they don't comprehend the discharge instruction. They have resistant personalities. They're being non-compliant. They want to be in the hospital. They have an inability to read the discharge instructions, or they don't have their discharge medication. So as we can see here, there's about 60% that feel that the patients don't really comprehend their discharge instructions, And there are some that have experience with a patient maybe having a resistant personality, and some that feel that the patient is non-compliant. I'm so glad. I really appreciate your candidness in answering these questions, and I think that we're all going to learn some new strategies on or reasons why patients don't always follow their discharge instructions, with some practical tips on how you can change that at your respective facility. So that would take us to polling question number 3, and that is where we want to ask you to make an assessment of where you or your hospital is at in relation to health literacy. And so identify which response aligns most closely with you. My hospital has a standardized method to assess health literacy for every patient. Or my hospital does not have a standardized method, but I have a standardized method for myself that I use to assess the patient's health literacy. Or I do not have an effective way to assess health literacy. And lastly, my hospital has a standardized method, but it's not effective. And so in our webinar today, a good portion of it is really focused on health literacy and how we can work with our patients and help them with their health literacy. So as we can see here, there are some hospitals do have a standardized method, or at least 2 hospitals do, and but the majority of hospitals, it seems that we don't really have an effective way to assess for health literacy. So hopefully we'll get some good pointers on that today. So the next slide, the link is there for the readmission change package. And the readmission change package has the most current evidence-based strategies to reduce readmissions. This is an excellent tool that's organized to help you eliminate some of those more common challenges that hospitals encounter in reducing readmissions. So I'd invite you to follow that link and go to the readmission package for some additional strategies. The next slide is the link for the HRET readmission listserv. And this is available for sharing of HRET resources, publicly available resources, best practices. Probably what I would say is that this is really an interactive site for you to share some of your successes and challenges and learn from peers across the nation on what their successes and challenges have been. So just to refresh your memory, our readmission measure is looking at all payers, all diagnoses, not planned readmissions for patients being readmitted to the same facility within 30 days of discharge. So this slide reflects for the California HEN at our baseline, which was in 2015, the readmission rate for our California HEN hospitals. At that time, we had 136 of our 179 hospitals reporting on this measure. You can see that we had about 30 hospitals that are in the top quartile with a readmission rate of less than 6.8. This next slide shows you where we're at in relation to readmissions over the length of this project, and it shows you the data by month. And you can see that we're hovering right around our baseline of about, our baseline, which was 8.9. And And at the bottom, in that little chart at the bottom, you'll see by month how many hospitals reported and what percentage that was. So our baseline, we had a total of 144 hospitals reporting, and that was 81% of our 179 hospitals. And then you can see in October we had 136 of 70, and just going down the line. So today, so that really brings us to our learning objectives for today. And that is we want to understand the barriers that patients experience after discharge, identify health literacy issues that lead most Americans to misunderstand instructions regarding their medications, follow-up care, and how to manage their disease processes. Identify an innovative strategy in line with population health management to not only prevent avoidable readmissions, but also to improve the health of the community as a whole. And to engage frontline staff in the changing landscape of healthcare through participation in a rewarding program based on strong partnerships with patients and families. And lastly, to establish a process for implementing a care transition team in facilities to reduce avoidable readmissions. So with that, I will turn the presentation over to our colleague, Leslie Hackett, the Executive Director of Nursing at Covenant Health Plainview in Plainview, Texas. She is responsible for the quality of service delivered by all nursing service areas, oversees the quality department along with radiology and laboratory, coordinates and directs the development and implementation of hospital-wide plans and programs to provide quality care, treatment, and services while meeting quality metrics and maintaining the fiscal integrity of the organization. It's my distinct honor to turn it over to you, Leslie.
Thank you, Martha, and I appreciate you guys giving us the opportunity to speak today. First of all, just a little bit about our hospital so you kind of know the size of our hospital, the services that we provide. Covenant Health Plainview is a faith-based nonprofit acute care hospital. We're located in the panhandle of Texas between Lubbock and Amarillo. We are part of the Covenant Health System out of Lubbock and St. Joseph Health System out of California, and just established an affiliation with Providence Healthcare. We are currently licensed for 68 beds, but undergoing a $40 million expansion and remodel project that will take us to about 85 beds. A variety of services including OBGYN, general surgery, cardiology, orthopedics, ophthalmology, and urology. And of course we have other services, radiology services, lab, respiratory therapy, those type of services in-house 24/7. So a fairly busy little hospital. Martha, it's not letting me advance the slide.
Okay. I'll take care of that. It has like a 2-second delay.
Okay. A little bit of history. I won't go into a lot of history because you guys understand the readmission reduction program that Medicare implemented. All of us are currently being affected by that. However, whenever this came out, we started reviewing our data. From data posted in 2013, we received a $49,000 penalty for 2014. 2013 and early 2014, our readmission rates were as high as 33% for all payers and 27% for Medicare and Medicaid patients. Now, looking at the penalty, of course, $39,000 doesn't seem real high for a large facility, but for small facilities, that can be a fairly big impact. Plus, we knew that penalty would continue to rise if we didn't get control of something. But outside the penalty, just the fact that we had readmission rates of 33% and 27% was extremely high and unacceptable to us, telling us that we needed to improve either our discharge planning or improve something in our care and our communication so that we were doing a better job for our patients. So getting started on this, when we first started on reducing our readmissions, we actually, implementing our care transition team was not our initial plan. We started by meeting with outside agencies to improve communications and processes. So we had a multidisciplinary team of agencies throughout our region and throughout our community, which involved our nursing homes that did SNF, rehab, nursing home care, long-term care, our home health agencies. We also involved Meals on Wheels with this, Adult Protective Services, local pharmacists, and people from those agencies, home health agencies and nursing homes within about a 30 to 45-mile radius of us. So we would meet monthly, and we really wanted to have a transparent type relationship to where if we were sending them patients back to their facilities and they felt like there were things that we could do better with our care or our handoff communication, that they would let us know about it and vice versa. We also were doing chart reviews within our hospital to find out why our patients were being readmitted. What we did notice in these chart reviews that a lot of our patients were being readmitted within 24 to 72 hours, which caused us to step back and look at some of our processes. When we did that, we were able to recognize a few things, just a couple examples. Some of our patients we noticed would be coming back with hypoxic episodes within just a 12, 24, 36-hour period. What we noticed was that we were admitting patients, putting them on oxygen, even if it was just a couple of liters nasal cannula, and we were identifying we were never doing a weaning process in the hospital. When the patient was discharged, that's the time the oxygen was removed and the patient was sent home. So we implemented a process that 24 hours prior to discharge, the patient would have weaning trials off the oxygen with activity to make sure that they were not having hypoxic episodes, that they may have to be sent home with oxygen. Another thing that we identified was that some of our nurses were not making follow-up appointments with primary care physicians. They were leaving that option up to the patients, and we found that a lot of patients weren't actually making those appointments. So we made it mandatory that they did the appointments on our side before the patients left the hospital and gave them those appointments. The other piece of that is we also discovered that if a patient was going to a nursing home, back to the nursing home, we were not making follow-up appointments for those patients. They were handing it off to the nursing homes to do, and a lot of those appointments were not being made. So 100% of our appointments, follow-up appointments, it's mandatory that the staff makes a follow-up appointment. Of course, unless it's a Sunday or Saturday afternoon when the clinics are closed. We also had case management assess 100% of our admissions. Prior to this, they were just taking consults to where if we identified an issue or the physician identified an issue that they may need assistance at home after discharge, that we were calling in case management at that time. But now we have, we don't wait for that. We just have case management go in and see all the patients. Usually they are able to get in there within 24 hours of admission, see the new patients, and assess if they are going to have any special discharge needs. The other thing we did, we even went out to some of the nursing homes and did educational in-services to nursing homes on how to recognize early signs of CHF exacerbation, COPD exacerbation, and things like that. We went, even though we did all of these processes, and I think everything we did was very, very good. You know, we built up good relationships with the other agencies. We were able to change some of our processes, and we got case management more active in the discharge planning. We just still were not seeing a reduction in our readmissions. So this is where our program came into play. We had an outside agency come in that was wanting to be our navigators. But, you know, as we talked to them, they didn't really have any data to show, you know, improvement in readmission in readmission rates on hospitals that they were working with. I think they had a very good program, but again, they weren't going to be getting into the homes until like 5 to 7 days after discharge when we were identifying problems within 24 to 72 hours. So as we were sitting there, I thought, you know, I don't see why we couldn't do this with our own people. So we listened to them and sent them on their way, and then got our heads together and developed this care transition program. Our first step was to implement a readmissions task force. And this was just a group of case managers, our case management department, our quality department, the nurse managers. We got these people together, and we would review cases. How can we set up this program? Also, our case managers monitored the LACE scores of our admissions, and I'll go over the LACE scores in just a minute if some of you aren't familiar with that. And this was a way of us to identify our high-risk patients for readmission. So when case management comes in the morning, they review all the LACE scores of the patient, and if they have a score of greater than or equal to 10 on their LACE score, then they would send those patients to us so that we could evaluate them to see if maybe they needed to be on this program. The patients were also identified in a morning huddle that we have on our med-surg floor. This also consists of our case managers, our people from our quality department, the charge nurses. Some of our hospitalists actually sit in on this and discuss some of their patients and their needs. We have a brief discussion about the patients. When are they planning on being discharged? Do they have any home needs? Are we seeing anything in the hospital that we need to address? And or do they need to be put on our care transition program and followed for 30 days post-discharge? Our nurse manager of our acute care services coordinates it. She's most familiar with the patients because most of them come from her floor. I kind of still help with it in the background. And then we set parameters for the population that we were going to see, and I'll go over that in just a minute also. Then we asked for some of our frontline staff. What we did was our goal was to have our frontline staff members actually go out and see these patients. This would give them the opportunity to build a relationship with our patients in our community. So the patients were familiar with the staff also, so they were trusting people that were coming into their homes. Also, if our nurses called our physicians were more likely to respond with the nurses that they had worked with than nurses that they were not familiar with. When I say we had volunteers from the frontline staff, we do pay our nurses to go out and see these patients. I just mean volunteer on that. We don't make nurses go out and do this. Nurses volunteer to be on the program and go out to the homes. Also, we had a lot of, I think this was part of a great success that we had. We had a lot of involvement from our CMO. I was a little concerned from the very beginning because our CMO is not pro home health agencies. He does use home health agencies, but he told us, he said, I like your program because I know your nurses. He said, if a home health agency calls me, he said, I don't know who I'm talking to. I don't know their assessment skills and their judgment. So if they call me, I'm going to tell them, have them go to the ER. So he said, if you guys call me, I know you've seen these patients before. I know you know their baseline, and I know you know what they look like when they were discharged. So he was more apt to trust our staff and our judgment than people that he was not familiar with. He was also very proactive in helping us develop our policies and our forms, and I'll go over some of the forms that we use here in just a minute. And he really wanted us to look at, when we were first developing our forms, he was very, wanted us to gear our forms and our education more towards socioeconomic issues. He really felt like a lot of our readmissions were related to a patient's socioeconomic situations. And not necessarily just intentionally being non-compliant. We also educated the staff on our goals, our duties, and our expectations. We made it very perfectly clear to the staff when we did their education that we are not going into the homes to do home health. We don't take in blood pressure machines. We don't take in stethoscopes. We don't take in pulse oximeters. We are strictly going into the homes to communicate and to educate the patients and to build relations with them. Next slide, Martha. Thank you. So the patients that we selected, we actually started out very small with just CHF, pneumonia, diabetes, and COPD. We have extended that to sepsis and hip and knee replacements since that's hitting several categories now. But when we started, our original goal was to do people with just a LACE score of greater than or equal to 10. Or people with a new diagnosis if they were high risk with any LACE score. And for those of you that aren't familiar with the LACE score, that involves the length of stay of the index admission, the acuity of the admission, comorbidities, and then the number of ED visits within the last 6 months. However, we found, once we started doing this, we found there was such a great need out in the community. We will see patients outside of this. We do see all payers. We see Medicare and Medicaid. And if we need to see other patients that some of the staff just feels like they need our help, we will do that. We were doing an education session for a new group of nurses the other day, and one of them raised her hand when we got to this slide, and she said, can we only see these type of patients? And I said, well, tell me why you're asking. And she said, well, I have a little elderly couple right now, he's in his 80s, and so is she. And they're going to change a lot of his blood pressure medicines and cardiac medications, but he doesn't fit in these categories. But he doesn't speak English, and I'm very concerned when he goes home that he's not going to fully understand what he's supposed to do and what he's going to take, and he'll end up back in the hospital. And I said, absolutely. If you feel like a patient needs help, let's go out and help them and get them situated at home. So she did follow that patient, and he ended up doing very well. Next slide. Okay, the forms that we use, very simple, very brief. The first form that we use is our education evaluation tool. The questions that we ask on this is actually a scoring system, and the questions address things such as, can they demonstrate understanding of their disease process and how to manage the disease? Do they have a PCP and knows how to contact the PCP? Can they identify early warning signs of worsening condition? Can they verbalize their medications, dosages, and reasons for taking the medications? And one of the biggest things is, do they have an organized system for taking medications? Do they have pill boxes? Do they understand and have the resources to get their medications, or are they getting several medications from different pharmacies? So that particular form there has a scoring system, and that form tells us how many times a week we need to see that patient. Our goal is to follow patients for 30 days. Some patients we have followed up to 2.5, 3 months just because they had the need. We do have one patient we've kind of been following in the background for about a year now. We're not really actively seeing him, but he still uses us as a resource. But most of them is 30 days. And if some patients are doing well after a couple of weeks and they are comfortable with everything, then we'll go ahead and release them also. The norm is we usually the first time end up seeing the patient 2 to 3 times a week, and then till we get them educated, we kind of work with them with their medications, and then we start tapering off, again, depending on what this score is. This next tool that we use is just a risk evaluation tool. This is not a scoring system. This is just for us to keep in the back of our heads that we need to address these situations, such as, do they have a risk for fall, assess their nutrition. Again, we use Meals on Wheels in our community a lot. They will provide meals up to 10 days post-hospitalization here. Adequacy of living conditions, tobacco, substance abuse, depression, or anxiety, family support involvement, and financial resources. With the depression and or anxiety, we actually had our MHMR agency here in this region placed a, with the 1115 waiver, they placed a counselor in our rural health clinic that the hospital runs, and we've been able to refer patients to her. She actually will come over to the hospital prior to discharge and introduce herself to patients that we feel like might need to go for, even if it's just 2 or 3 sessions of counseling. And she's been very, very helpful. A lot of times if she's willing to come over to the hospital and meet the patients to go before they go home, they seem to be a lot more willing to follow up with her. So she's been a great asset for us too. Next slide. Okay, education for the staff. We do a lot of training on health literacy. Literacy skills seems to be the strongest predictor of a person's health status. We do have this video link up here on YouTube. This is a health literacy video. It is very impactful. We show it to our nurses. I have showed it to very many people. If you guys will take time to make note of that and watch it in your free time, when you watch it, these are the type of frustrations that we are seeing from our patients. Health literacy also, patients have a reduced ability to understand labels and health messages. They have a greater use of emergency departments. They have higher mortality among the elderly, and there's, of course, a shorter life expectancy with both physical and mental health. Next slide. Just a few brief facts. Most health information is written at the 10th grade level or higher, and that's one thing we want to stress to our nurses is that sometimes they can't just hand people a piece of paper and expect them to read it, that we have to sit down and explain it and go over it with them. The average person in the U.S. reads at an 8th grade level, 20% at the 5th grade level or below, 40%. Senior citizens read at or below the 5th grade level. 50% of African Americans and Hispanics read at or below the 5th grade level, and poor outcomes occur because health systems are too hard for 90% of U.S. adults to use. With that being said, that is extremely, I think that is an extreme problem that we have in the United States today. We've tried to assist several of our patients with some of their social. We're not social workers and we don't have a social worker, but sometimes we kind of help with that aspect of it, and we have ran into brick wall after brick wall after brick wall. But we're stubborn and we don't give up, but I know a lot of patients do. If they're going to have to hold online for 30 minutes, or 20 minutes, they're just going to give up and not continue. So we have found that is a big barrier for some of our patients. Next slide. And then, of course, CMS says 75% of readmissions are preventable, and Joint Commission says that 75% of preventable readmissions are a result of miscommunication, costing about $7,500 more per year per person and $238 billion annually in the United States. Next slide. Outcomes achieved. When we implemented this program, we were able to reduce our readmissions from a baseline of 11.2% in fiscal year 2014 down to 5.4% in 2015. It has been in place for a year. After that first year of being placed, we actually had 4 consecutive months where we had a readmission rate of 0. So we were pretty proud of that. Patient satisfaction. We had and this is one of the biggest things that I think was a success for us, is that we really noticed a big shift in our culture with our frontline staff. And they were even able to pass some of this on to our hospitalists that were working with the patients too. There's one thing that we stress to our nurses whenever we educate them. There are 3 terms that they are not allowed to use. That is non-compliant, frequent flyers, and drug seekers. Those terms have very negative connotations. It can flat run a hospital stay for a patient to where it makes everybody be dismissive about their needs and cause them not to listen. And whenever we started doing this, I actually heard nurses correcting each other. Some of the nurses that have seen these patients, somebody say, well, they're just not compliant, and they would turn to them and say, they are compliant, they just don't have the resources to be compliant. So, and that's what we were finding. A lot of our patients that had been labeled in the hospital as being non-compliant, once we started following them and got in the homes and found out the barriers that they had, a lot of times they were not compliant intentionally. They did not have the resources to be compliant. So that was a great thing for our culture. Really got our staff engaged in changing their image about the way that they looked at patients. These are some of our slides just on our 30-day unplanned readmissions. If you see, we have trended downward. We had a little episode in December where we had a bump up, and just so you know how focused you have to stay on the program, around August, I lost a nurse manager that was coordinating the program for me. At that time, she moved out of town. So during that time frame, I was trying to get a new nurse manager in place, get them hired and get them fixed. I was trying to do CNO work, run the program, run acute care services, and we did have some patients fall through the cracks. So so you do have to keep a handle on it. Anytime we have let up just a little bit, we see our readmissions start to go back up. So definitely you've got to watch it and you've got to keep a handle on it. Next slide.
So that really brings us to the questions.
Oh, okay.
And so there is one question that came in the chat box, Leslie, and Lynn was asking is how do you pay for the post-charge visits if you're not charging as a qualified home health visit? And I know I think you touched on this very briefly, but if you could just explain it, that would be great.
Okay. Yeah, it hasn't really cost us much money at all. What we do, the nurses are paid depending on what they are working that week. During our period of low census, a lot of times we have to call nurses off, so they have to use their paid time off hours, and then they run out, and they get frustrated. So some of our nurses chose to do this just so they could assure that they were getting their 36 hours a week. So if they go out, if we had to send them home on call, they were using some of that time to go see patients. We will pay them a per diem rate if they've worked their 36 hours that week, and we pay them by the hour. So, if they see 4 patients in an hour, if they see, takes them 3 hours to see 1 patient. One thing we do encourage them, and the reason why we pay them by the hour, is that I don't want nurses rushing. There's been times we've literally spent 2.5 to 3 hours in the homes trying to get their medication straightened out, calling the pharmacies, helping them call the physicians to try to get things organized for them. And sometimes it just takes 15 minutes, but we tell them we don't want you in and out and rushing. This is about sitting down with them, looking through their medications, educating them, taking time with them, and building those relationships. The budget, we use the budget actually comes out of the med-surg budget. As we grow, we may have to change that. We really didn't have a budget to start with, but this past year we did add a budget so that we can pay extra salaries for it. If the patients have emergency needs, if we need to help with assistance with medications, to get them through a couple of days before they can get a check or find other resources, we're using that budget for that. And so it just hasn't been real costly, actually. I just did an unofficial 6-month guesstimation whenever we first started the program, and I think paying the girls' mileage and salaries, we guesstimated maybe about $5,000 in 6 months. We don't charge the patients for the visit, but if it's helping us reduce our overall readmission and avoid that penalty, it's definitely paying off in the long run.
Another question that just came to mind for me, Leslie, is what about documentation? Do the nurses go back and document in their inpatient chart, or what do you do for documentation on these patients?
Those forms with the education tool and the risk evaluation tool, they document on those forms, so it's paper documentation. And then what we do, we turn those, after we finish seeing the patient, we turn those forms into medical records, and they scan them into the chart that was the last discharge. So if the physicians want to go back, if the patient is readmitted and the physicians want to go back to that previous discharge, they can see what we did on the care transition team.
Great. And then, excellent. Then the other question that came in was regarding the 3 statements that you don't allow. No drug seekers, non-compliant, and what was the third?
They're not allowed to use the terms non-compliant, frequent flyers, and drug seekers.
Oh, frequent flyers. Great.
Frequent flyers. And those are just negative connotations. And, and we use those terms all the time. But we notice when people quit using those terms, the patients don't get labeled. And we found that people get more involved with their care if we don't label them.
Correct. Well, Leslie, does anyone else have any other questions? There was one more on mobile medical units, and there is some work being done on that in the Los Angeles region, Marianne. And if you tell me what facility you're at, I can connect with you on that afterwards. But Leslie, this was so wonderful. I mean, like I told you when we met in person, I want to come back and I want to work for you because I want to go see those patients. And I mean,
I go out and see my patients myself. I go out and see patients myself because it's just so rewarding, going out and really and I think that's helped to be successful because I kind of knew what to teach people when I actually went out and saw these things myself.
Right.
very rewarding to go out and to really sit down and you find out the barriers that people really experience out there.
Great,
So,
great.
yeah, it's been a great experience.
Well, thank you so much for sharing it, and there are a lot of kudos in the chat box. You know, you've made a lot of great work, and we really appreciate you being so open with it. I am going to go ahead and turn the discussion over to Kim Workmeister. Kim Workmeister is the clinical improvement educator at that works with us at the Hospital Quality Institute and has been very integral in the CalHEN program. And she has done a lot of work with health literacy, and she has offered to share a little bit more on health literacy with us all today. So, Kim?
Great, thank you so much. And Leslie, I cannot tell you how happy it makes my heart to hear someone else saying, please don't use the words non-compliant or frequent flyer or drug seekers, because that has been the root of so many of our readmissions issues. Is we're just not actually understanding our patients' needs or our patients' understanding of what we're trying to ask them to do following discharge. So I think it's just a wonderful, simple concept that you have put in place that has made such a tremendous impact. And I think it doesn't matter if you're from a small organization or a large organization. It can work the same in any of them. This is just a great story, and I really appreciate you telling it. We want to spend just a couple of minutes talking about the concept of health literacy, because it does have such a dramatic effect on readmissions. And there are a lot of reasons for health literacy to be an issue, and part of that is that we have so many issues just in general with the way that we communicate with one another. Leaving out even any health information, just basic communication. There is a lot of opportunity for us to misunderstand the message that is coming to us, and this silly sign is one example of that, but there are many that are no laughing matter too. And when it comes to barriers of communication with patients, one of the biggest barriers for us is low health literacy. The other is those socioeconomic factors that we can tap into also that we just talked about. Now, first we need to understand what health literacy really means. And when we say that term, we're talking about that degree to which individuals have the capacity to obtain, process, understand basic health information. And it's also important to know that approximately 90% of adults in this country have difficulty using everyday health information that's routinely available to them. And I'm not talking about reading medical textbooks. They have difficulty understanding basic health information. And this study right here is one example of that. In a study done a few years ago across 3 states, almost 400 primary care patients were surveyed. What they did is they gave them a handful of medication bottles with prescription labels on them, just like the kind any of us get from our local drugstore. And when they went back and talked with each one of those patients, 46% of them, almost half of them, did not understand the basic instructions on at least one of the labels that they looked at. Basic information here, 46%. And then when they went back and delved a little bit deeper and stratified them by those who already had adequate general literacy, were reading at a high level, still almost 40% of them still missed at least one label. So those things that we think are quite simple are not necessarily as easily understood by our patients as we think that they are. Now, the federal government has taken a stance on this, and they what the U.S. Department of Health and Human Services does is every decade they have something called the Healthy People Goal. We completed Healthy People 2010, and now we're in the midst of Healthy People 2020, and there are a wide multitude of goals that are included in this. But for the 2020 goals, one of them is that we would figure out as healthcare providers how to deliver our information to our patients in ways that are understandable and beneficial to health. So the onus is on us, not on patients, that everyone has the right to health information that helps them make informed decisions. Now, when we're going through and trying to find out, so we say, great, so about half of my patients probably don't understand what we're telling them when we're giving them health information. Well, how do I find out who those patients are? And there are a few ways to do that. One is just looking at some general red flags that seem to be the same amongst many folks who do have low health literacy, and you will recognize these: frequently missed appointments, incomplete registration forms, they don't take their medications as prescribed, or what has also been described as non-compliant in other areas. They identify pills by looking at them. They'll tell you that the little orange pill is their water pill. They're really unable to give coherent, sequential history of their medical background too, of their health history. And there's a lot of lack of follow-through on tests or referrals. They don't show up to the lab the next day when we told them to. Just using red flags, though, is obviously not going to identify everyone for us. There are some that do and some that don't. There are some very specific tools that are available from AHRQ that can be downloaded, and I'll give you that link at the end here, but they're pretty short, quick assessments or standardized assessments so that we can give to our patients and identify in advance. Okay, here we go. Here's a patient we know has low health literacy. So hopefully then if you're going to be doing standardized assessments, there needs to be something in place then as a response to finding those patients. And so how do we deal with those patients, and what do we do differently for those patients? But probably the best bet, since we're not going to identify every one of them, we may not have the opportunity to do these standardized assessments on our patients, is to just use what we've been doing all along when it comes to infection prevention and apply that principle to health literacy and use universal precautions for health literacy. And what that means in this realm is that we would structure the delivery of care as if everyone that we come in contact with might have limited health literacy. And even those patients who wouldn't normally fit that category, being in the hospital and the anxiety and the stress that adds, we know that takes away their ability to understand and comprehend and retain the information that we're giving to them. So truly everyone does benefit from having clearer communication when it comes to what we are expecting them to do following discharge. Now, there are some strategies then that you can put in place for when using these universal precautions to make it simple for everyone. The first is to just focus on what the patient needs to know and what the patient needs to do. No one can benefit from 6 or 7 pages of discharge instructions. Focus on those few bullet points. After discharge, you have to do A, B, and C, and your condition is a result of A, B, and C. We don't need, again, medical textbooks for our patients. Use teach-back methods when you are providing information for the patients, and I'll talk about that in a moment too. Demonstrate exactly, physically show them what you want them to do and have them physically show you back. Draw pictures, and I'll talk about how those can look too. And if you're going to be giving out written educational materials, make sure that they are clearly written. They're not overly complex. They don't contain information that's written at a graduate level. We're talking about very simple strategies. So now teach-back is a great process for ensuring that our patients are actually understanding. But what it really does is help us to gauge how effective we are in doing that education for our patients. So in a patient that's getting ready to go home, when you are providing those discharge instructions, a great way to use teach-back is to explain, what it is that you want the patient to know and to do after the fact, and then say, okay, now I want to make sure that I explained it correctly. Can you just tell me in your words how you understand the plan? That way patients don't feel like we're testing them, because that's not the point. We don't want to add more stress and have them think that we're testing them. We're testing our ability. And you can also say, I want to make sure that I explained it clearly. I'm testing me here. Can you tell me how you'll take your medicine tomorrow when you go home? Or can you tell me how you're going to obtain your medicine is probably the first question to ask there. Patient teaching with visuals is another very effective, very simple mechanism for ensuring that our patients understand what it is that we are trying to say. many of us are visual learners. I'm one of them. I do much better if I can see a picture or a diagram or understand the flow of how everything is supposed to work once I'm discharged. Many health drawings are way overly complicated. Again, get away from textbooks. It is okay to do a stick-figure drawing or a little Valentine heart to describe what's happening in their cardiovascular system that we need them to know. Again, simple is best. And we do know that patients appreciate when we show them how to do something, we pull it out and demonstrate it, because then they say that they can do it. Let them show us right back, and they can do it. So that's kind of using like simulation as a form of teaching. And we know simulation is very effective for all of us in keeping up our core competencies. Simulation is just as effective for patients. And then just a few other tips too. Make sure to use plain language, limit the information, be very specific and concrete, teach back, and also be very positive and hopeful and empowering. A lot of patients are leaving the hospital and they are scared. They have no idea what's happening. And just a little bit of positive feedback for them and letting them know that, okay, so you're probably going to have a hard time getting an appointment. If they're still doing their own appointments, script something out for them for what to say if they're given a hard time or a roadblock when trying to make their follow-up appointment. Do something that's very empowering for them. And then just some examples of what I mean by plain language then too. We say annually and think that we all understand that what that means, but just say every year instead of annually. Or instead of hypertension, not everyone understands that. Say high blood pressure. That's understood by a lot more people. And then these are the resources I told you I gave you from AHRQ for those health literacy assessments. And there's also a great teach-back resource too that's a complete training system for teach-back, which is, if you have not yet put that set up in your organization, it's a great place to start too. I know we're at a polling question here too, and I see that Lynn has a comment in here too that they saw when she was involved in a research study at Stanford where they saw a big increase in discharge teaching success when the nurse had the patient use a highlighter and highlight the key points. Yes, that's fantastic. So we know that they understand what the key points are then too. That's fantastic. So this brings us to our polling question, and this is our final polling question. I am going to turn it over to Martha to take us out here and go with the polling question.
Okay, great. So if you just would go ahead and answer that polling question, that is, readmissions are a result of patients not following discharge instructions because either they are not comprehending the discharge instructions, have a resistant personality, being non-compliant, wanting to be in the hospital, inability to read, or not having their discharge met. And as we can see, everybody has identified that it really is an issue of not comprehending the discharge instructions. So then if we can go to I guess I do that, the next polling question. And what I want to ask you, so we have these webinars and there's a lot of good information that's shared. And I want to just challenge each of you to ask you, what are you going to do by next week? Are you going to share what you learned on health literacy with the team at your staff meeting? Are you going to test a health literacy tool? Are you going to dig deeper on your next readmission to identify where the gap was or is in the discharge plan? Or are you going to request a colleague to observe you in giving discharge instructions and ask them for their feedback? How am I doing? Where could I, maybe my language, I didn't use plain language. Could you help? Sometimes we do things so innately that we don't even have that picture of ourselves where we're just using maybe jargon and not even realizing it. Or lastly, maybe you'll observe a colleague giving discharge instructions and offer them some feedback. So I would really challenge you, ask you each to really call yourself to action and take something that you learned here today and share that with your colleagues. And so it looks like quite a few of you are going to share it at a staff meeting or with your peers, and that's great. I'm happy to see that maybe you've learned something new today. So the next is just the poster, and you may or may not be familiar with it. This is a poster format that we've been using at the in the CalHEN process for capturing some of the work that's being done with the improvement project. And so thank you, Leslie, for sharing the work that you guys have been able to accomplish there at Plainview. And lastly, I really want to thank our speakers today. Leslie, you did an awesome job and really have a great program that I think really supports not only the patient but the professional development of your staff. And Kim, you gave us some great lead-ins to evaluating our patients on their health literacy and some strategies to help make our teaching and our instructions and our work with our patients perhaps more real or easily adaptable to the patient. So thank you both. If you have any questions, if anybody wants to stay on the lines, we'll open up the lines, and if you want to ask the questions, I'll stay on for a few moments. But again, thank you, Leslie and Kim, for your input today.
Thank you.
Any questions?
Line unmuted.
Well, the last thing I would like to say, I also want to thank all of you that participated in taking time out of your busy days to listen on the webinar today, because we know that everybody, you all have very busy schedules. The hospitals are tremendously busy these days, so we appreciate you taking the time out of your busy day, and would ask that you go ahead and do the evaluation and collect your CEUs. Thank you very much. Can we be on private chat?